In his presentation today, Saab will outline New Zealand's Psychosocial Support Plan and Framework. He will draw on his experience in Canterbury after the earthquakes and consider what we learned from that experience that we can apply as we respond to COVID-19. Saab will connect with some of the ideas that Dr. Julie Highfield discussed in her webinar last week, particularly around how we can provide wellbeing and psychological support, not just to individuals, but organisations as well. Lastly, Saab will consider whether we are prepared to make a big change to meet the big change we're going through right now. Saab, we are really delighted to have you join us today, and we're really looking forward to your presentation. At this point, I'll hand over to you.
Kia ora koutou, kia ora. Thank you, Sean. Thank you, Adam. Thank you to Healthcare NZ for your invitation today. I really, really appreciate it. Let me just get my screen shared, and hopefully you're all able to see that first opening slide here. And I know that everyone's really doing a lot of Zoom or Doxy meetings at the moment, whatever your format you're using. So I'll try to keep things relatively brisk, still hopefully imparting some useful and usable information for you, pointing you to some of the resources I've developed, alerting you to what I believe is some of the key thinking, comparisons and ways of working, and then finally round up with what I've learned so far on my coronavirus journey and what the future may bring in terms of challenges and opportunities too. So my focus is on public mental health. Ever since I made the leap over to public policy type work as part of my portfolio of work, which was in about 2006, that's been the case. But it also was before I trained as a clinician too, when I managed the first study in the UK into the scale of occupational stress in the population from 1997 to 2000, because before then it was just considered malingering. So for the majority of my working career as a psychologist, that's been my focus, whether I realized it at the time or not. And so just as an aside, isn't it interesting how we create narratives of our past to fit in with the idea that we have of ourselves in it at any point in time, that we're attempting to either create or reinforce that narrative. And that's something perhaps we can return to when we speak about how psychologists can be most helpful. And I think it also speaks to the last webinar when Julie spoke about how perhaps therapy isn't perhaps the most helpful or welcomed thing that psychologists could be doing from the point of view of the people who are receiving it. But perhaps it's more of a light checking in and a sense of awareness of the wider context that people are operating in, and how being borne in mind by someone and offering a sense of continuity and or bridging to a new future might actually be a really helpful function that we can perform. So what's been happening with you over the last few weeks? I think most people have been taken up with a certain COVID-19 virus. I started off at the end of January with some media commentary on the impacts of quarantine for those returning back to New Zealand at that point in time, based upon the work that I did for the Ministry of Health back in the days when we were planning for a possible H5N1 pandemic, which I assisted for in the response here in New Zealand. And I was then the H1 vaccine policy coordinator in the UK government, but that's a different story entirely. I'll talk about that another time maybe. So then into February, we could start to see very clearly that this was going to be an issue globally, and eventually it would get to New Zealand. And it was really just a matter of when and not if. So I stepped up the blogging on my website, which is now being picked up by the media here in New Zealand. And I started to think more actively about how I might best be able to help as we progressed into March. I was doing some more coordinated work with the Science Media Centre here in New Zealand. And I would encourage you, if you're a person who's working in psychologically informed ways and you're in a position to be able to do this sort of commentary and public facing work, I would really encourage you to step forward to try that. The Science Media Centre is a great group of people who support academics and clinicians who are able to offer their views to the media with training that they can offer you too. So you can help to portray accurate and helpful pictures to the wider public. And I'll talk about the importance of building mental models throughout this talk, because I think that that's really important for us when we are dealing with situations of uncertainty and anxiety, to build a framework such that people can start to build some flexible predictability into their lives, so that they can think about what are the possibilities and then what's the path that they would like to take in that. And then you can start to problem solve when things deviate off course. But I'll return back to that. So March came around and we had our own private COVID-19 scare as a family when we all had to get tested, which was not a particularly pleasant experience if anybody else has been through that. And I talk about the dissociation I actually experienced in a video that I created, but more about that when I talk about the YouTube channel and what's on there. But I was, again, picked up in the media, and I think people realized that actually this is a common experience when you're going through a painful medical procedure or something that's at least uncomfortable. And so again, it was just trying to just take away a bit of the mystery for those people who perhaps were having to come forward for testing. It was really unclear as to how many people were going to have to do that at the time, and really starting to try to destigmatize that particular procedure that they may have to do. What's the next slide? Here we go. So later that month, and that already feels like such a long time ago, I got a call from central government where I worked on and off in New Zealand since 2006. And I was contracted into the National Emergency Management Agency, which is based at the National Crisis Management Centre for 1 month. And the role that I had there was an interesting one. It was, I was asked to provide strategic communications advice and guidance around psychosocial support and emergency events. So I got to go into work for 1 day, just 1 day at alert level 3, because yeah, we've got issues at home where I need to manage kind of exposure and all the rest of it. So although I'm classified as an essential worker, I stayed at home for the entirety of alert level 4. And so actually, Adam, now's a good time to do poll 1 if you can, please. Thank you. Great, that's brilliant, thank you. So before I tell you what I actually did on that first day of work, I am going to run you through the main points of the framework for psychosocial support. The latest version was published in 2016, which is an iteration from the 2007 version. And that was developed after the Canterbury Earthquake's experience, to try to take up as much learning from that as possible, or the lessons that were offered from that at least. And it was published just as Kaikoura was just happening. And so let me outline some of the key concepts first. And that's that most people are going to be affected by an emergency, and they will experience perhaps some level of distress. So negative experiences and emotions that don't necessarily indicate problems with deeper psychological functioning. And we know that distress is far more prevalent than mental health disorders as we go through an emergency. So for most people, that distress is tolerable, short-lived. Thank you, that's brilliant. And depends upon the duration of the acute and the secondary stresses. And I'll talk a little bit more about what's a secondary stressor afterwards. And that's interesting. Yes, in all kinds of ways, mainly means more Zoom calls as well. Yeah, I think that's probably a good representative experience there. Now, all of those that go through an emergency are likely to benefit from some kind of psychosocial support, but it's really important that we understand what that means. For most people, the distress that they experience is going to be able to be eased with the care and the support of the families, whānau, friends, and their communities, the people who they normally connect with in order to get that support. But for a smaller proportion of people, they're going to need access to more specialized mental health services. Now, that might be in primary care, or it might be through going through a stepped care process to more tailored interventions that suit their needs. So the assessment is really important, and assessing what need and how it may be met. Now, the interesting thing here is that actually what we see is that during an emergency, we see something like 5 to 10% of people perhaps need more sort of tertiary level PTSD, chronic depression, or severe anxiety, those sorts of responses. So if we think about the prevalence of those sorts of disorders in the community as is, it's not that much of an increase. But over a chronic emergency or a disaster where it has several waves perhaps, and you have several waves of intensity building upon inequalities, or people who have built secondary coping mechanisms to get them through the initial period, but then that starts to fall apart for them as they move forwards in time, then we can start to see people coming forwards for help at that stage. So what we saw in Canterbury, and I'll talk about this a little bit more, is that some people didn't actually come forwards until years 3 to 4 in that response. And that was when things were starting to fall apart for them, but they'd also put themselves to the back of the queue because they'd heard a lot of talk about how psychological therapies were a scarce resource, and they thought that other people needed it more. So that's an interesting dynamic that I think we also have to think about when we talk about availability of therapies. And that goes for institutions as well as lower down the community sort of level of things in terms of services. So the primary objective of psychosocial recovery is to try to protect people from and to minimize any further harm through the social and psychological consequences of an emergency, and then to try to enhance their emotional, social, and physical well-being. And it's important to understand that actually it's not a return to normality. It's about positively adapting to a changed reality. And that is what we are going to be dealing with here as we move forwards in time. This is really actually a discontinuity. And thinking about how we bridge from pre-COVID to post-COVID for many people is going to be their main work, their main task that we're going to be able to perhaps assist them with. And what that looks like, we'll come on to. So psychosocial support aims to try to improve psychosocial well-being in 3 core domains. The first one is supporting and promoting human capacity. So people's strengths and the values by which they live their lives. The second is to improve social ecology, because we know that connection, social connectedness, social support is the biggest predictor of those people who do better coming through emergencies. And the last one is understanding the influence of culture and value systems and their importance alongside these individual and social expectations about what the future may look like. So really understanding people's orientation and what is important to them in their lives. I'll give you one example. When State Highway 1 was being rebuilt, well, actually, when it was being cleared after the Canterbury earthquakes, a lot of that debris was just kind of shoveled straight out into the sea. Now, lots of people who live in that area actually rely upon kaimoana for 2 to 3 main meals a week. And there was a lot of disquiet about what that was going to do to their ecological systems and being able to go out and fish and catch that kai. And that wasn't really taken into account because New Zealand Transport Agency wasn't around the core government group that sat around the table understanding psychosocial issues. So who gets to be part of the conversation? And co-determination then becomes really, really important as we map our way through to the future. So these are big conversations, which I'll again return to in my final slide. How much are we actually buying into the idea of co-determination and a combined future where we all get to have a say and where we all have agency? So our psychosocial well-being depends upon having resources from all of these 3 domains and to be able to respond to the emergency conditions and events. And the challenging circumstances can deplete these resources, resulting in the need for external interventions to try to bolster them and to build psychosocial well-being for individuals and communities. What we know is that people who are affected by emergencies can experience acute and or chronic distress. But looking back on their experience on these events, those affected emphasize the importance of the interventions that build and sustain those supportive partnerships. And those partnerships may be within families and whānau, existing or new social support networks, or wider communities. And so what we need to do is to build effective interventions to reduce distress after emergencies that focus on self-efficacy, community participation, and also, I would argue, collective action as well. And I think that that's the direction of travel that we will start to see response frameworks in New Zealand starting to move towards, the importance of collective action as well as individual experience. So no matter how long the post-emergency period continues, the evidence indicates that delivering timely and appropriate psychosocial interventions to support affected individuals and communities has to be based on the accurate assessment of the psychosocial problems and the associated need. So this really is the stepped care model. But what we're looking at here is a stepped care model where we have many more players involved. This is not just the health system. It's understanding what are the basic needs for people who are going through emergencies and how do we coordinate such that all the agencies involved all the NGOs involved, all the community organisations that are the small glue that keeps New Zealand going at many different levels of our country. How are they all involved in delivering those needs, and how do we assess them over time as we move forward and we understand how those needs are changing? And we do that through both preventative and curative actions. So the preventive actions are the ones that help to reduce the risk of negative psychosocial problems. And the curative actions involve helping individuals and communities to either face or overcome these problems and to adapt to their changing circumstances. So in this way, we're looking at focusing our interventions at not just a population level, but we're also looking at informing and supporting individuals in their families and whānau as well. So as I said before, resilience really is a process of positively adapting and continuing to develop in response to adversity and change. So it's not a destination. It really is a continual process. And I think that was an early error in the Canterbury Earthquake response, is that it was framed as a personal attribute rather than a process of people coming together, and the capital that's involved in communities that's used and depleted, but then can be bolstered, and also people coming together to create something different that's separate and bigger than individuals working alone. And again, underpinning all of that is social support and social capital. In order for that to work, we have to have the buy-in from the community and their involvement, and that involves building trust and engagement. So the conversations that happen between central and local government, between central government and national NGOs, between local government and local organisations, building from the flax roots up, all become incredibly important when we're looking at sustainable responses to emergencies and disasters. So really thinking about, well, what's the balance that needs to be struck between quality assurance and national standards to make sure that people get safe, good quality interventions, but also understanding that actually these need to be locally driven, locally designed, and where we can see innovation taking place in how the touch points deliver into real people's lives. So that balance is a constant line that we need to be walking very carefully. So thinking about that, those main concepts, what we designed in the Psychosocial Support Framework were these 8 principles. And the number one really here is to think about doing no harm. Anything that we do needs to be measured in terms of the impact that it has, because unless we're measuring, we don't know whether it's having a potential harmful impact or not. And I think it is a core responsibility that we measure what it is that's going on, and we check in with communities and individuals as they move forward through a disaster. We're also looking at establishing and maintaining health equity and human rights. There's a lot of work that still needs to be done here. So promoting the human rights of all affected people, and to make provisions for at-risk people and hard-to-reach communities, so that recovery actions don't create or increase inequalities. And I know there's a lot of thinking that's going on around this at the moment. We see, the people living with disabilities, also being a group here who may be disproportionately affected by the lack of opportunities for them to take agency and charge of their own recovery and journey through COVID-19 as we get out of level 3 and into level 2 and beyond, whenever that happens. So what we want to do, as well as building this community and stakeholder engagement, is to try to promote self-help and self-efficacy as much as possible. We're trying to restore people's agency, which is really difficult. When you think about the Canterbury earthquakes, you're thinking about a threat that happens unpredictably, and it happened time and time again. If you think about COVID-19, it's something that's not visible. You can't see it. And it also has a time lag. The incubation period could be anywhere between 5 days and 21 days. And you also have the risk of silent transmission too. So it really is difficult for the human mind to get its head around well, what are the actions that I need to do and how do I know if it's making a difference? And this is why measurement and dynamic tracking is really, really important for any kind of intervention that we make. We all dial in to the 1 o'clock press conference, just like we all looked at the GeoNet app to figure out and get a number that helps us to understand and make sense of what's going on. Just as we make use of that in our everyday lives, we as clinicians and people who are delivering services also need to understand the impact that we are having on people's lives. And then finally, this integrated all agencies approach and the multi-layered targeted supports, I think I've talked about a little bit already. So I don't want to linger too much on that when I've got so much other stuff that I need to talk about. But what I do want to talk about here is the response and recovery workers. Now, this is new. Compared to the 2007 version. I think what we've learned and what Julie talked about in her experience and the work that she was talking about last week is the impacts of burnout and compassion fatigue. And we know that in Canterbury, people started managing themselves out of frontline facing roles after a while. So what are the implications of that happening en masse if that happened during or after COVID-19? So we're still also, I think, struggling to recognize the dual impact of working to help others whilst going through the same thing ourselves. And we can also extend this out to how we use or how supervision is going to work. Where do we get the supervision from? Where it comes from a place that is different enough to make a difference, if I can draw from systemic models. If we're captured by the same experience and events, or at least where they are dissimilar enough for us to actually introduce new information into that relationship or our relationship with our experience, such that we get a new insight. I think that's something that we need to think about carefully. How do we carve out enough space and room for reflection with skilled practitioners? Now, that's a role that I played when I was in Canterbury, because I was knowledgeable enough to know the issues that were happening on the ground, but I wasn't captured by them because I didn't live in Canterbury, or by Wellington thinking, because I wasn't working full-time in a Wellington government agency. But that was a regional event. What happens now in a national event, in an event that's also impacting our Australian colleagues? I think that's something that we need to think about quite carefully. I don't think there's any easy off-the-shelf answer here, and I'd be interested to hear your reflections on this in a while too. And whilst we're on Canterbury and COVID, I've been thinking a bit about whether it can guide us, how much it can guide us, because the danger is, in all emergencies, is that we prepare for the emergency that we've just experienced, rather than the one that's facing us. So there is a lot of conversation around what can we learn from Canterbury. Less so now, I think. I think that that's kind of calmed down a bit. There are some similarities, but there are also some big differences. So we need to be careful how we extrapolate. So I've talked about the regional versus national and international. In Canterbury, we saw an acute impact, particularly after the second quake involving loss of life. But it was chronic. It happened over a long period of time. There were different epicenters, so different parts of the city and the region were affected, and we had multiple impacts. And similarly here with COVID-19, internationally at least, we're looking at the initial impact, and then there was the impact of all the physical distancing and all the other measures that have been taken to limit the spread of the disease and the virus spread. But there may also be multiple impacts. We know from 1918, the influenza epidemic, that there were 3 waves. And everybody's certainly gearing up and talking about a potential second wave. So we need to be thinking about multiple impacts there. For the Canterbury earthquake sequence, we saw varied impacts, particularly around geography. And we saw also varied impacts here. And if we think about how different ethnic groups have, some have been victimized as a result of just belonging to that group. And that story is continuing. I think the Human Rights Commissioner just put out a report either yesterday or the day before. We have primary fear and anxiety with the Canterbury quakes, the fear of the quake and possible loss of life itself. And similarly for COVID-19, we have fear of catching the virus and what that might mean for ourselves, but also our loved ones, people who we are not able to see right now. So there's a primary fear that's driving the anxiety there. But we also have the secondary stresses. Now, the secondary stresses are the policy decisions or the bureaucracy that then starts to have a cumulative impact that is above and beyond the impact that the primary stresses had. So in Canterbury, we're talking about the EQC insurance quagmire that people found themselves caught up in, are still caught up in, many people. And then we had the poor quality rebuilds that were happening. So people are now stuck in that quagmire as well. And similarly here, the public health measures have had the impact of really severely affecting economic activity. And the continued public health measures all around the world means that, you know, our second biggest industry is severely impacted by that. So we really need to be thinking about how the secondary stresses are actually the things that are having an impact on the lives of people that may be turning up at our services, at our clinic doors. It's not necessarily about the COVID-19 virus, it's about all the other policies that have been enacted that were necessary at the time, but are now having the secondary impact upon their lived experience. We have the impact of a shifting timeline as well. We don't actually know when this is going to end. We don't know when we're going to get out of level 3. We don't know what level 2 is going to look like just yet. We don't know what that's going to look like in terms of international travel or being able to visit relatives overseas. We are an incredibly internationally connected population. We have many people, many family members overseas that we are not able to see right now, not physically anyway. And similarly for Canterbury, we had no way of knowing where the next quake was going to be centered, what was going to happen, how severe it was going to be, or whether that was going to have an impact, or whether it was going to be an insurance event, which added another dimension to our distress. We also have a newly at-risk group in both of these different phenomena. We have the at-risk group that was new, the people between around about 30 and 54 who started presenting around year 3 and 4 in Canterbury, people who had no experience of trying to navigate a government system in order to get assistance to help them in their lives. That might be financial assistance or trying to get through the EQC nightmare, or actually just turning up to mental health services saying that I'm struggling and I have no clue as to how I'm going to navigate the system to get the help I need for myself or perhaps my children. Similarly here with COVID-19, we have a newly at-risk groups that are emerging. We don't know who these people are going to be yet. It may be the 55-year-old who's worked in a local travel agency for 20 years and is going to find it very, very difficult to get any kind of employment in the new market in some of these provincial towns. That's just one example. There's many, many more. And then we also have the unintended consequences of decisions that are being made now that we can't actually fast forward into the future and see what they're going to look like. So yes, I think we've talked a little bit about AQC there, and that's one of the things there. You know, going from an organisation of 12 people to try to deal with all the claims that were going on in Canterbury at the time was a big, big ask. So, back into my first day at level 3, working at the National Emergency Management Agency. On that first day, I did 2 things. And the first thing I did was I drew up a paper called Communications for Psychosocial Experience. And the first thing I did in that paper was to emphasize a problems of living approach as an alternative way of thinking about secondary stresses that I thought may resonate more. So we can see that in the case of COVID-19, we have at alert level 4, we would have restricted movement, we would have concerns about income, having adequate food and shelter. If you remember back in the day, trying to actually go to the supermarket still is, but it certainly was then quite a mission to be able to do that. And thinking about all the different steps that you would have to take in order to protect yourself, but then also not to become a vector of transmission to other people either your loved ones at home or other people that you may see at the supermarket workers too. All of that took a lot of effort and thinking to try to do that. Access to medicines and health support. We've seen that actually people stopped going to GP appointments. We've seen that excess deaths in the UK that have occurred because people were not going to appointments to help them manage their long-term conditions. It's not something we looked at carefully here yet, but I'm sure that data is going to be looked at quite soon. But then also managing relationships in close confinement, getting bored or over-ruminating upon issues over which you have no control. And all of these other problems started to come to the forefront where people don't have a lot to occupy themselves. So as well as trying to address concerns about COVID-19 and what's being done to manage the threat, thinking about addressing these problems in living became a critical and ongoing concern as we moved through that time in level 4. And it was important for New Zealanders to have a channel back to the policymakers and communications teams so that government could understand the issues that people were grappling with. So the 4 principles that I asked people in the communications departments to bear in mind from a psychological well-being point of view were these 4. That is, number 1, resources. People, as well as the connection that they need, which is the 3rd one here, people need things and they need information. They need concrete and specific messaging about where things can be obtained, food, medicines, and other critical services, but also where to go for trusted sources of information, but also how to manage that information flow. You may have been seeing people in your clinics where they're feeling quite overwhelmed with the amount of information that they're A, have to process, and B, choosing to process by constantly news checking the whole time. So thinking about how to limit news exposure to perhaps 2 or 3 times today so that people don't miss the important things that they should be hearing, but also are not overexposed to that. The second one that I kept returning to and I urged people to return to was structure. So offering structure and suggested activities as to how people could organize their time during alert level 4. Having a structure, I was communicating to them, was acting like a container so that the anxiety people experience doesn't spill out and either stop people from doing things that they needed to do or becomes a contagious emotion either within households or between households via online networks and video calls. And structure also helps to occupy time, which then becomes a bigger challenge as we move through, to, I don't know if you remember back to sort of like weeks 2 and 3 were the kind of hard yards during alert level 4. And to solve that, what I proposed was that people were encouraged to share the way that they were solving the problem through social media with models of fun and excellence as a good way to celebrate how New Zealanders were responding to the challenge positively, and also providing ideas for others to adapt and to try it in their own households. You remember the bears in people's windows. This is a way of occupying children, but then everybody could participate. Even if they didn't have a bear, they would put stuffed crocodiles or Darth Vaders or whatever it was that they had handy. And the kids would be walking around, ticking off the number of bears and the other funny things that they saw too. These were community acts coming together that were spontaneous, spread through social media, and then put up as examples in the media that offer messages of hope. Hope becomes incredibly important as we go through periods like this in emergencies. So having a narrative of hope is something that I thought that needed to be structured as well. Connection, we've talked about a little bit here. We know it's the biggest protector in times of emergencies, but we also know that inequalities in terms of access to digital means of communication and to stay in touch can be magnified here. I noted that Wi-Fi's were turned off in public libraries fairly early on in the piece at alert level 4, not to deny people connection, but they were concerned about congregation and people coming together, and they weren't going to be far enough apart from each other. So I know that some commercial operations like Skinny Jump came on board, where you could pay $5, get a free modem that was subsidized by the government, and you'd get 30 gigs of data for that $5. And I think you could apply for help with that $5 if you needed to as well. So these are innovations that help to try to think about and deal with these inequalities of digital access, which I think are going to need to continue. I remember when the Kaikoura earthquakes happened, when I went down there to assist, the first thing I saw was big crowds of people outside of the hospital. And they weren't waiting for medical appointments. It was the only place that had working Wi-Fi at the time. So it really is a basic need, particularly if a lot of the messaging is coming out via the internet. And the fourth one I think that people have talked about a lot, and the leadership of the government has been certainly talking about this a lot, is the idea of empathy and the fact that tone and kindness are important. And the critical factor here is not to rush to a solution or to provide an information referral and see that as a transaction that is then closed. What I was talking to the communication people about was that actually an offer, a request for help is often a request for an understanding and a relationship. It's not necessarily about the information, and just trying to enlighten them that actually when we get to an emergency, often what people are desiring is a relationship, not necessarily just the information, and just to keep bearing that in mind. And so making sure that they had two-way channels of communication, not just broadcast, which I think was something that they were doing quite well anyway. So the next thing that I did was to try to organize a content strategy, organized by my experience, but also what the framework told us that we could expect from weeks 1 to 4 as we went through the alert level. At alert level 4, firm enough to offer some structure, but loose enough to be adapted and to accommodate and assimilate new unexpected information as we went through. So I'm just going to put through the next 4 slides the sorts of things that I thought were going to come through and come up, and I think that it was reasonably good. There were a couple of things that didn't happen which I thought might, but it's interesting. So these were written on the last day of level 3. So in week 1, I thought the psychological experiences and the behavioral targets for any kind of communication should be around trying to get structure in the days, organizing how families will function, just trying to get roles and thinking about who does what within a family, and organizing people in that way, helping them to do that themselves. Information overload was going to be an issue, and people would be watching the case numbers fairly quickly, and that might be a source of primary anxiety. And then looking at trying to encourage people to adhere to the physical distancing behaviors as much as possible and to stay local, but to continue to socialize. The narrative that the case numbers were going to continue to rise, just to try to get the primary anxiety in context. And the main themes to address here was, these are the sorts of things that people are going to be wondering. Is it going to work? Is it worth the pain of trying to go through these public health measures in order to try to eliminate COVID-19? And starting to see those messages of hope really, really early. I remember having a meeting with the media and with Sarah back in year 3 of the Canterbury Earthquake response and recovery. And the media were looking for stories of hope. But the government agencies were taking weeks to clear permission to release these stories because of the way that the government bureaucracy works. And so what I was trying to do here was to really talk to the government and say, you actually need to get this going pretty quickly in order to get hope out in the population, and having those stories in media fairly quickly on. Thinking about grief support is something that we talked about in week 1 as well. And I know that this is very topical at the moment, and it may be something that you're involved with too, but how do we grieve for people when we cannot be near them physically? I think is going to become a really big issue worldwide, and certainly for New Zealanders who have family overseas as well. Week 2, you'll see here some of the things that I was talking about. This idea of stories of health system overload, including problems accessing mental health supports, particularly through the 1737 number. But now that's, I think it was in week 3, week 4, there was a whole slew of new apps and ways of engaging with online digital ways of getting support were released through the Ministry of Health. I talked a little bit about poor weather, just making sure that we were taking some, that's interesting, that's relatively low awareness of the Psychosocial Support in Emergencies framework. And it doesn't surprise me. When we did the work to redo the 2016 edition, hardly anybody had heard about the 2007 edition. So I would encourage you to download that from the Ministry of Health website. Perhaps Adam could send you a link when he sends you the slides from this talk as well. So yes, just continuing on here, the other experiences and behavioural targets were things like income and government support would become difficult to access, or it wasn't quick enough. And we would start to hear stories of vulnerable communities whose needs were not being met. And so what I was trying to ask the comms people to start to deal with and start thinking about now, around messages of hope contingent upon adhering to recommended behaviours. We're doing this as a team of 5 million, let's finish the job. All those sorts of messages that you've been hearing so far. We've invested so much into getting into this point, why would we waste it now? I've heard some people saying, this is kind of like near the final whistle when we're winning 1-0, let's not screw this up. And then the comms around relationship management and repair when having to deal with each other on a daily basis, and people are irritated, tired, frustrated, and anxious. So really just thinking about, aside from the issues around domestic violence and not being able to actually be away from the perpetrator, relationship issues occurring at a different level. And then as we go further forward into time, I'm a little bit more cautious about what it is that I'm thinking that we're going to see. But I start to perhaps draw out what are we going to do if we stay at level 3, and what are we going to do if we're going to have to stay at level 4. But one of the things I thought would emerge around this time is the hope of developing technologies like the antibody tests, which have turned out to be not particularly good at detecting whether people have, or accurate as to predicting as to whether people have antibodies in them or not. But there was a big sort of surge of hope of actually this might be a way out and we can actually return back to normal. Week 3 was the sort of, well, what's normal going to look like in the rest of our lives, and what's New Zealand's story of coming through all of this. But what I wanted to do was to make sure that people were aware that all New Zealanders needed to have a voice in this. All New Zealanders needed to be seen in describing their experience, good or bad, or their concerns about the future. But also more kind of scanning around the foreign press as to thinking about, well, what are they doing? What is it that we could be doing as well? And then in the final week, preparing this for the exit or extension of alert level 4, which we ended up in for another 5 days, but then the continuing theme of adherence and preparing people for a backlash against the strict adherence and movement protocols, which is what we did start to see. You know, all these models were predicting this many deaths and they didn't happen. Well, that's because we started the strategy pretty early on compared to other countries. So that's why we didn't see the impact that we could have had. But, you know, public health is constantly struggling with this issue, because you kind of predict the worst. And if you do what the public health officials say, it doesn't happen. And people say, well, what were you worried about? That constantly happens in public health. So you can see in the plan here the sorts of things that I was thinking about. And I was working with not only government agencies, but also the advertising agency that were doing the whole of the Unite for COVID-19 website, and all the messaging that you hear on the radio and you see on TV as well, which was incredibly interesting from a psychologist's point of view, to be able to work with the people who were designing those messages, designing all the content. It was, I think, a really interesting, influential position to be in. And I really appreciated their work, their ethic, and their dedication. It really was quite incredible to see. And these were people assembled from the comms teams from all different agencies and serving different groups all around central government, as well as local government too. So it was a really interesting dynamic team. So in parallel to what I was doing here at central government, what I did was I made a commitment to try to help people build mental models. So what I committed to doing was to research, script, direct, record, edit, and produce daily well-being videos for each and every day of Alert Level 4, including the extension. So that was 33 videos. So I think I regretted this around about day 26, when it became clear that it probably was going to be an extension. And I probably, you know, I've been making YouTube videos for about 1.5 years now, and I thought I could do this. And I did, and it was tiring, and it was interesting to come up with a content strategy. But I guess you can see here in the created playlist here, there's the 5 sort of themes. There's the your brain reacting to coronavirus times, where people may be interested in, oh, why is my brain, why am I thinking this kind of stuff? I want some kind of explanation around, you know, things like negativity bias, or why is it that I'm constantly looking at for bad news here, and, you know, the positive stuff just seems to kind of like slide off. Social isolation and COVID-19 was a big issue that we were worried about. So encouraging people to connect in digitally healthy ways. Better relationships in coronavirus times, when people are stuck in the same house with people who they wouldn't normally be stuck in the house with this for this amount of time. You know, relationships would start to perhaps come under some kind of strain. And then there's the coping with coronavirus, more focused on the emotional side of things and how to deal with that. But then the living with coronavirus, like how do you get on with doing your living tasks whilst we're in this situation? So there's one here on working from home. And there's lots more here that you can see. There's the moral fatigue on what's it like to go supermarket shopping, and the 5 better tips that you can see here as well for sleeping. So yeah, I'd encourage you to have a look at that and come along and subscribe to that channel. You can also perhaps recommend that for other people who may be experiencing things that they may be able to benefit from watching some of these videos. They have been shared by the Ministry of Health, but also the Depression Initiative as well, and commercial operations like Datacom for their employees, and that was in New Zealand and in Australia too. So I think that they have been useful and they're all freely available. So what happens next? Perhaps if, Adam, the final poll here would be good. I think you've done number 3, but, or if you could do 3 and 4, that would be fantastic. Great. So whilst we're doing that, I'll talk about how we need to continue to help people to build mental models of behavior that will help to keep them safe, and for them to also to be able to access help as we hopefully descend into level 2 and beyond. We also need to recognize that we do live in this densely connected country in terms of connections to family and friends overseas, which produces challenges to work for well-being for those people who are restricted from making these kinds of journeys for the foreseeable future. The last thing that they're going to want to do is to transit through a country that perhaps isn't clear of COVID-19 or not as clear as they would like it to be, and then act as a vector of transmission to their vulnerable adult who may be living overseas. That's certainly the position that I find myself in. The research seems to tell us that we're unlikely to get a rush of clients coming through the doors quite yet. The problem of living lens gives us a bit of a clue here that perhaps tells us what people are going to be coming to us for. They're more likely to be needing resources, and they're also needing to deal with tools that deal with their precariousness and the uncertainty that they're experiencing. We know that if people's basic needs are met, food, shelter, power, warmth, internet connections nowadays, and social connections through that, then 80% of them in any kind of normal emergency will be okay. That's not to say that they won't experience distress, because many will, but that this distress is going to be a common experience, that once the problems of living are addressed, then the mental health issues become less of a risk. But what we have seen is an increase in use of substances around the world during this time. And partly that's around self-medication during anxiety, but there's also reports that people are perhaps drinking more as a way to socialize in physically distant ways, but also through boredom too, and lack of stimulation. That's what they're doing because it's available. And so one task then from a public mental health point of view is to help people to build mental models as to how they will cope when challenges occur, and keeping them sticking to the behavior that they would like to be doing, particularly if they've already got problems with, perhaps alcohol use that's already been identified. But what we've witnessed here, make no mistake about it, is an amazing feat of collective action and efficacy. So not only were we encouraged and guided to act in a collective way to protect everyone, but especially the most at-risk New Zealanders, but we were also encouraged to believe that it was possible and to create and foster a sense of collective agency, that doing it together was the way that we were going to achieve it, which is really difficult when trying to deal with an unseen threat with a time delay to seeing how it's reacting to our efforts to deal with it. Because we humans are not good at directing ourselves towards actions that don't have an immediate consequence. Just look at how slowly we have woken up to the threat of climate change at a population level, at least. So this is promising. And much research has gone into investigating and confirming that collective action in both Western traditions and indigenous psychologies, these are really important in marshalling community resources to direct real change in people's lives. So I expect to see more thinking along that line in future developments. So how can we improve a sense of agency that helps to reduce uncertainty? And it also relates to that idea that Julie talks about, the circle of control, that I've also been using in my videos too. And this is really interesting. Thank you. That's really, really helpful to look at. I'll look at that in a bit more detail, and we can return to these sorts of issues later on. So what can we do as psychologists or people who work in psychologically informed ways, or those people who are managing or directing these services? Well, firstly, we can do preventive work. Encouraging people to take preventive action. So you'll be familiar, hopefully, with the 5 ways to well-being, which are well evidenced ways that people can take preventive action to improve their well-being on a daily basis. This idea of connecting, giving, taking notice, keeping on learning and getting active. And in the UK, they've extended that in the NHS by using clangers. So clangers is the 5 ways to well-being with 3 added steps here. The ability to be able to relax, the ability to choose and access and to be able to afford to eat well, and also to be able to sleep as well. We noticed this again if I return back to Canterbury in about year 3 or 4. Imagine if I gave you a newborn baby and they were going to stay a newborn baby and you were going to have them for 2 years and they were going to interrupt your sleep every night, and then you were going to drive to work and everybody else in the city has had the same experience. They all had a newborn baby that's kept them awake all night and you're all driving around like zombies the whole time and you are going to have accidents. And this is what's going to happen. So the ability to sleep becomes really, really important if you have that cumulative deficit across a whole city or across a whole nation. I think that one of the things that is going to become really important is the importance of our therapeutic alliances, as well as our technical skills that we're going to actually have to use in quite different ways over delivering and having relationships over video. I think that that's going to take some adapting to, and I think that there's a gap there perhaps on how we skill ourselves up to do that. So thinking, Sean, if that might be a professional development need that could be met. Thinking about what your role might be, and it may not be what you think it is, because actually what we found was that people needed navigation and they needed advocates on their behalf when they were trying to get resources from other agencies where they weren't necessarily listening or they found it too confusing as to where to go. So finding out how you can best help your clients, which might actually be quite confronting for you because it may not be the help that you think that you're going to be doing. What they may need is a way down the pyramid of needs to get their basic needs met. And your role might be to help them to access that and to act as an advocate using that problems of living as the lens to see where psychologically informed work can help them get what they actually need. So I would say prepare yourself for helplessness. You may feel like there is so much that you could be doing, but that's not where your client may not be at that particular point in time. Once their basic needs are met, then other things may rise to the surface, but that really is the #1 priority. The other thing that I think people are experiencing right now, and I certainly was fatigue. Fatigue, and perhaps even that's showing itself in people's lives as apathy. And people just kind of feeling like that, well, they can't motivate themselves to do things. I had about 3 days after we finished the level 4 videos where I just kind of couldn't do much other than to like do the basics and go to sleep. And I think that I experienced a really big adrenaline come down off that. And I think that that's happening at the moment for a lot of people. And I think the mental model that helps us to think about this is that of transitions and the work that we do if we're working with perhaps young adults or people moving from sort of like childhood into the tween sort of like area, or moving out of home, or moving from working to not working, or when children leave home. All of these transitions, all the mental models that we kind of try to help people to build to cope and deal with these sorts of transitions. I think if we think about discontinuities and what we learn in developmental psychology around trajectories of future pathways, how we help people to build bridges to different trajectories or a continuation of their trajectory, I think is going to become really, really important work for us to be doing. And I always come back to resources, structure, connection, and empathy the whole time. So for my final slides, my final reflections, one of the things I said to my wife right at the very beginning when I started this work about 6 weeks ago now was that my lodestars are structure and empathy. If I deviate too far away from structure and empathy, please pull me back and ask me what I'm doing. And I guess one of the things that I added to that fairly early on was a commitment to purpose. The idea that actually you're very clear about what it is that you're trying to achieve, as well as using the tools of structure and empathy in order to help people to progress along the journey. What is it that you're trying to do here? And what is it the other person wants to do? What's their purpose in order to be able to live and to actually pay the bills? Is that their purpose? In which case, then that's what you structure them. You help them with the structure of being able to do that. And we're kind as to the means by which we do that and help them. And the last one I would say would be something, again, Julie talked about last week, and that's the idea of pacing. The idea of being able to see the long game here, that this is going to be continuing for quite a long time, and being able to replenish and nourish yourself is something that's going to be really important. And that supervision piece that I talked about earlier becomes even more important. The final slide here is really a question about, are we prepared to respond to the big changes that we're seeing in how we live our lives, with equally disruptive and large changes in how we, whether we're clinicians or services or funders or commissioners, how do we seek to protect and support the health and well-being of New Zealanders? Because if the appetite is there for big change, then the required systemic reset is to recognise the importance of the impact of secondary stresses on the well-being of New Zealanders. And this means systemic change recognises the impact of the social determinants of well-being, the wider and directly experienced impacts of inequality to access to services, to educational and economic opportunities, to good food, necessary heating, and safe and healthy housing. These are the basic needs, because building a better mental health response will mean next to nothing and will be a poor investment unless these issues are addressed at the same time. Otherwise, all we're building is a better conveyor belt to patch people up and send them out into the same problematic environments that caused them to seek help in the first place. So by all means, absolutely, there's work to be done in improving access, to create new touch points, to make it easier for people to access the mental health and well-being help they need. But take the opportunity to fix the causes, the determinants of mental health. And there will be likely to be fewer people needing more intensive forms of specialist support during the recovery. Thank you for having me, and thanks for your attention. I'm happy to hand back to Sean now for questions.
Well, Sab, I hope we're going to have you for a little bit longer. Look, so thank you first of all, and thank you for such an incredibly informative presentation. I'm not going to attempt to sum up everything that you spoke about, because you covered a huge breadth of information there. All of it incredibly useful. I think you shared with us the work that you're doing, both at a social and a policy level, but also in this presentation covered how we can work as individuals to provide effective support through this time. I was really drawn to the 4 principles that you outlined: resources, structure, and just a note on that, I think you can see how that has fed into that idea of structure, how that's fed into the alert level system that we've created in this country, and the importance, I think, of that system. Sorry, a co-worker is coming in. You look great. It's my son's birthday today. He's just
Happy birthday!
7. Where was I? The alert level system. I just think it's shown how effective that is to give people a sense of where they are now, what's expected of them, and what can be expected in the future. Those mental models, as you said, incredibly important. The importance of connection and empathy, and your point that what we need to do is not just provide information, but also create a relationship. Those are some of the points that have really stuck with me. Look, we've got the queue. I see a number of questions and answers have started to come through. If you haven't asked any questions and you'd like to, please open up that the Q&A. Please go to the Q&A icon at the bottom of your screen and open that up. As I said before, you can also upvote on some of the questions already asked. So please get into that. I see a number of questions have already come through. So I'd like to start with a question from myself. You said earlier that resilience isn't just a personal attribute. It's created by the context in which we live. It's about enhancing social support and community participation, and I couldn't agree more with you there. The question that I have is that I think there's many of us who are here on the webinar this morning who are leaders in organisations or hold roles where they can naturally influence and impact social change at a broad level. But we also have a number of health specialists joining the webinar today who are used to working individually with people. And I'm really interested in how you think we can contribute to the building of resilience at a community level.
Sorry, Sean, I missed the bit where you said how I think. There was and then there was a little bit after that went blank. Can you say that again?
Oh, I think my main question is how for people who are doing individual work with people, how can we contribute to creating that community level resilience building that you've been talking about?
Yeah, I think it's a really difficult challenge for us now because we're working through a different mode of transmission of information, but also a different mode of nurturing relationships. That's because what we may normally do in the way that we look or our tone and how it is that we communicate with each other over video call is very different to how it is that you would be doing it in real life. And from a community perspective, if you may have been doing perhaps community meetings, or you'd be working with whānau or with wider systems, I think how we use the video structure in order to be able to collaborate more and use more collaborative platforms where we can use co-determined outcomes, but also setting co-determined goals. I think that becomes really important. Now, there are structures that have been used for things like political processes, like Lumio. Lumio is something that I think the Inspiral group do. Now, the Inspiral are kind of like a group of kind of solopreneurs who kind of come together and they work together to solve particular projects and problems that they're all working upon. So it may be that actually in order to really effectively get good collective action around co-determined goals, we need to be thinking about taking more of a facilitative role, and we facilitate this co-determination process. And psychologists, we can be psychologically informed in that facilitative role, but perhaps we need to be thinking quite widely and perhaps borrowing from other fields as to what's worked there in order to produce meaningful change.
Mm-hmm. Well, there's, as you're speaking, Sab, it occurs to me that while there's a number of challenges at the moment about doing that, there's also opportunities. And I think we've all realized how easy it is to connect, collaborate and co-design with people dispersed through the country and through the world, actually, as we use, get more and more used to using video technology.
Yeah, absolutely. It feels a lot smaller. It feels, can feel quite a lot more efficient, but you kind of need to do the work to make sure everybody's on the same page to start off with, otherwise you end up with just a lot of wasted activity.
Yeah. Hey, I'd love to now move into some of the questions that we're getting through the question and answer section of Zoom. So, do you have an average latency time for symptom exposure? What I mean by this is that I know people in the Christchurch area still show symptoms now, 8-9 years later. Are we anticipating this for COVID-19?
Yeah, I don't think there's no easy answers to any of these questions. I think what we witnessed in Christchurch was stuff that we would have seen before. Okay, so we're all familiar with the idea that people have resource themselves that they draw upon. Now, that might be financial resource that they are able to tap into that gets them through the worrying thing. And then they're able to regenerate that resource again, or they're able to do that from other places, in which case there's not going to be probably an issue other than worry for this person. For other people, perhaps, consider the person who has got a child who is finding it difficult to sleep on their own at night because of fear or anxiety. And so you invite them into your bedroom, and a few nights turns into 2 years. And suddenly you've got your partner sleeping on the couch, and your son won't sleep in their bed because they can't have the light off. It's only when something new comes into that system that then the symptom comes to the notice of either the parents or somebody else. So I know of several cases where when primary school children had to change school and they started to go to college, and then suddenly the workload changed and suddenly they wanted to change their behavior themselves, then that's when the symptom emerged in terms of something that actually they need assistance with. So I guess it's back to the kind of the old kind of formula of, it's a problem if it's getting in the way of how it is that you want to live your life, or it's becoming so large that it's actually taking up all the time that to try to manage that in your life, or it's so disturbing emotionally for you that actually it forces you to seek help.
Mm.
So I think that that's what happens in Christchurch, is that there's that, and plus the idea that people actually were stepping back because they felt like it was a scarce resource, so other people need it more than I do. And it got to a point where they were like, well, no, actually now it's my turn. So I think all of these things underpin why it is that people presented later, plus many, many more reasons. So I don't think that there's an average latency time for symptom exposure. I think it's all the contextual factors that drive whether that symptom comes to light or becomes disturbing enough to people that they actually seek help.
Okay, thank you very much. The next question here is from Melissa. Hi, Dr. Jahal. Thank you for this wonderful presentation. People with intellectual disabilities definitely have magnified inequalities of digital access, as you mentioned. Many people don't even have their own phone and would need engagement to learn how to use one. Do you have any advice on increasing people's self-determination here and in this type of context?
Yeah, I think if we're in a situation where we are really relying upon technology in order to help people to access the services that they need, then we kind of need to do what the Ministry of Education have done. So for those people, for those kids that were internet connected, but they didn't have a device in order to be able to connect with it, then they gave them one. It's not clear as to whether it's a loan or whether they're going to be able to keep it, but that's what they did in order for them to access the educational opportunity that they are required to enable them to access. So I think that similarly here, if people don't have devices or they don't have access, then I think we need to take positive steps in order to make sure that not only do they have the device, but they also have the ability to learn how to use it and operate it such that they can get the help that they need. I think it's really, really important to be inclusive as possible here.
I think, as you said, a crisis like this enhances some of the inequities and the layers of inequity that we experience across our society. So the next question, I'm really interested in your answer to this next question. Hi Saab, what sort of service structures, agencies do we need to have and develop to meet post-COVID psychological needs of New Zealanders?
One of the things I think that we could possibly think about doing more flexibly is where we locate our psychological resources and assets within a service and how they flow between various different levels. So there's not a lot of point having, and this is by no means a criticism of anyone or clinicians or service structures individually, but I think that actually having a whole ton of resource, perhaps waiting for people to come in tertiary level service structures or service facilities, whereas actually what's needed is primary care, working with GPs, then I think that we need to be thinking quite carefully about job responsibilities, job definitions, and also professional development for those people who are working in these services, such that they are able to assist where the need is at in a more flexible way. But that then speaks to a training issue and a continuing professional development issue, and also an expectations as to what jobs and where people are going to be deployed issue. So the basic answer is I would like to see more fluid movement of psychological resource across primary, secondary and tertiary levels of the needs triangle, such that we are able to deploy those psychological resources to where the need is at.
How important, just picking up on that, how important is access? Then I think one of the points that you're making there is that we don't, as you said as part of your presentation, is that people are holding back. It seems people may be holding back from accessing support at the moment. If that continues, of course, there's going to be a compounding of issues that people may experience. So how important is the ability to access easily psychologically based and wellbeing services at a time like this?
From what I've read and heard about other services around the world, like, so I'm thinking about the IAPT services in the UK. I think that they were a great idea, and then they rolled them out, and then they found that they weren't making a big difference until they tried one thing. That thing was that they really upped their game on assessment, and they really looked at making sure that the assessment was done by really skilled clinicians, and making sure that they were sent to the right part of the service in order to make the biggest difference or the potential for the biggest impact in their lived experience. And I think once they started doing that, then they started to see better results. So I think that if we were looking at a more fluid kind of structure for where psychological resources go and where they sit, I think the key to unlocking that is having a really, really good assessment structure and having very skilled clinicians doing that assessment.
Sad, I couldn't agree with you more. We've been part of supporting the Picky initiative in Wellington, which is a free wellbeing service delivered through primary care for 18 to 25-year-olds. To ensuring that we had, as you said, really skilled clinicians taking that first call or reviewing those initial referrals to say, is this someone who needs some group therapy? Is this someone who's actually needs quite intensive support tomorrow, or determining do they need some social supports and some connections with friends and peers. So yeah, I absolutely agree. Not only do we need to be thinking about access and how we can promote and make services easily accessible to people, we also need to make sure there's that upfront triage process to ensure people are getting the right support. Thank you. Okay, next question here that's come through. As psychologists, do you think we need to prepare ourselves to provide telepsychology on a long-term basis?
It looks that way. It certainly is looking that way, because I think that it's an interesting. I think there might be a little bit of a reset that happens within people's tolerance for risk within the general population, and I think that that's something that some people they're going to fly through this, not a problem. I don't mind going out and get coffee or takeaways or queuing up for McDonald's or whatever it is. I don't really care about my exposure because I don't believe it's a risk. That's not me. I'm just saying, hypothetical me. But I think for a lot of people, they're going to be perhaps anxious about transmission, and that might be one of the things that they're concerned about. But also they're possibly going to be more risk averse in many different areas of their lives and really reassessing, well, what is it that they want to do now and in the future? So I think that telepsychology may not remain such an exclusive way of working, but I think it's going to take a bigger proportion of our work. So I'd say that the answer would be probably you'll be doing it more often and with a greater number of people. You may not be doing it all the time, but I think it's worth thinking about how you do this on a long-term basis for sure.
We've definitely been thinking about how to provide safe, effective, and also culturally appropriate tele and video psychology. One of the things I've been hearing from colleagues is just the additional mental effort that is involved in providing express emotion and intent, but also to be able to read the body language of the person on the other line. People are just talking about how difficult and challenging and wearying that is actually to be providing sessions through tele or video conferencing.
I have to agree with you. I remember going back to like my early training. I think one of the feedback that I got from one of my supervisors was that I was constantly trying to second guess what was going on my face. And they really kind of like, encouraged me to reflect upon that and to perhaps let go of that. And what I find is that actually Zoom triggers all of that stuff again for me, because I'm constantly thinking about my own expression and what am I leaking and what's this communicating. And that's fine. It's a tool, right? I've learned to use this. This is a tool. Perhaps it's revealing what it is that I really think. But I think you're right. It's not normal, or it's not usual for us to be looking at our own faces whilst we're having a communication with a client in this way. So really thinking about how we manage that in order for us to be more effective, or at least perhaps even thinking about that as another tool for us to use as well. It certainly throws up a lot of different ways of working.
Yeah, it strikes me that we've got a two-way mirror for ourselves as we're doing a Zoom or video conference session. Okay, the next question coming through. What about the points of resiliency that help promote recovery? What positive psychological traits or strategies were discovered?
So I think we talked about hope, and I think that that's really, really important. The ability to see what a future might look like that isn't a pessimistic worst case scenario, but actually a more realistic but perhaps more positive view. But then I think also a mental model that outlines the pathway to that better future as well. You know, what are the sorts of things that I can do, that I have control of, in order to influence such that that becomes more likely, not predetermined, but more likely. So I think, again, it's this idea of psychological flexibility, but having messages of hope that inform where it is that and how it is that we're going to use that flexibility. But again, in order to be able to use that flexibility, we have to feel safe. So the relationship then becomes the container for developing that safety, for practicing that flexibility, with an overarching message of hope as to what things could look like in the future. So I think that that's the kind of the package that kind of like needs to be used, I think, in terms of growing and developing those skills for people and the strategies by which to do it.
Okay. Thank you, Saab. Next question. Look, you're being pulled as someone who's from Joy. Joy's saying that she's interested in what an economic stimulus package would look like that took psychosocial well-being into consideration.
Oh, that's way above my pay grade. I would be interested in. It's something that I've kind of like resisted in the past for many different reasons, but I actually think that there's value in thinking about a UBI right now, and thinking about something that enables people to get their basic needs met. Because I think that part of the issue is going to be, how is it that we enable people to take steps forward into this new future in a way that where they're able to provide for their own basic needs, for their family's basic needs, but then to create something different, to add value to a co-determined future. And I don't think people are going to feel able, they're not going to have the cognitive space, they're not going to have the motivation to be able to do that unless they get their basic needs met. So how we do that whilst economic activity is at a low is going to be very difficult. We could take more targeted approaches. We could think about reforms of the tax system to make more, a wealth taxation system rather than an earned income taxation system. These are big, big structural changes, which I don't think people are going to be willing to take on whilst everything else is happening. So I think that what's going to happen is that this is going to be funded by debt to start off with. And then as we progress into the future, I think that then we're going to have some big questions to answer around what does a fair distribution look like in terms of revenue and taxation for New Zealand, and how is it that we can free people to use their potential in ways that aren't about living hand to mouth and trying to figure out where the next dollar is going to come from.
Yes, but just on that, I'm interested in your experience in Canterbury post the earthquakes, and I guess well, a number of us are wondering about how much change is actually going to result to come about as a result of the experience we're all going through. And I think many of us are hopeful. And I saw a question in here about what we can learn and also apply from the work that you're doing to issues such as climate change. But there's a lot of hope for things being done differently in the future. And I'm wondering what you, given your experience in Canterbury, what you would have to say about the ability to create change or otherwise after an experience like this.
I would say that it all lies in our ability to be able to harness the power of collective action. If we do this, or if we try to do this on our own or in small groups, I think it will get lost. So I think, as always, the power will be in organizing and in collective action in order to be loud enough in a co-determined future to be able to say, well, no, this is important. This is important as to how it is that we wish to live our lives. And we think that whoever it is that we vote for needs to pay attention to that. So I think it is about organizing and collective action. I think that there is a recognition that collective action is the only way that you're going to get things done. And this is an opportunity. It's a break point. It's a discontinuity. And we will move on quickly. And so there is an opportunity here to start staking out the ground and saying, look at what has happened in terms of rewilding of urban environments. Look at what has happened in terms of particulate emissions around at some of our big cities. We're not saying that we have to go back to horse and cart, but there are different ways that we could be doing things, and this gives us some insight on how do we capitalize upon that. It won't change unless there is collective action that takes place in order to force it through.
Thank you very much, Saab. I'm going to take one more question and then close today's session down. This one is: did you give comms advice to the National Party?
No, my comms advice was purely to government agencies.
Okay. All right. Thank you very much. Thank you very much, Saab. I know that there are more questions sitting here, and I apologise to anyone who has asked a question who we haven't got time to get round to. Saab, is there a way, if people are wanting to connect with you in some way after today's session, is there any? How would you suggest they do that?
Yeah, you can connect with me on LinkedIn, and that's a good way to find me. So I'm quite easy to find. I think Saab Johal NZ on LinkedIn, or you can also connect with me on YouTube or Twitter. So at Saab, SARB, is a good way to find me as well on Twitter. Yeah, so happy to enter into the conversations about the questions you've got.
Once again, thank you very much, Saab. It's been an incredibly informative presentation, and you've given us lots to think about and go away, and a lot of ideas, I think, to bring into our personal practice or work wherever that may be. This is the second in our series of webinars that's been focusing on how we provide effective psychological and wellbeing support as we respond to COVID-19. We're currently considering whether we extend this series, and we will be in touch with all of you with more information about any future webinars. If there is someone that you'd like to hear from, please get in touch, or if there's a topic that you'd like us to look at getting someone to talk on as part of the series, do get in touch and let me know. Thank you for joining us, everyone. I'm going to close with a karakia. Kia tau iho ti manaki tangata o te waiho naro, ki runga ki tena o tātou. Kia mahia te hua makihiki, toi te whakaro, toi te kupu, toi te aroha, toi te manaka tangata e, Māori ora, hui e, taki e.
Kia ora.
Thanks, everyone.